Thanks everybody for having me. That's where I am. And I was, in between Sue, a general pediatrician. So after I finished my time with the naval residency, that was at what was then Bethesda Naval Hospital, now it's Walter Reed. I spent 4 years as a general pediatrician, 2 on Guam and 2 back at Bethesda and at the medical school there at USIS before I started my fellowship. What?
I want to take up the whole hour.
Yeah, I know. So, but I think, you know, it changes your outlook, I think, a little bit when you spend 4 years doing general peds before you go into a subspecialty. Yeah. Today we're going to talk about bacteriophages. So I was thinking, you know, you're probably going to have a bunch of questions about this, but there's not really any current practical implications for you, like, because there are no licensed phages for us to use, but hopefully in the future we will be able to use them. And it is cutting edge, and there's a lot of interesting things going on. But then we can spend some time at the end because maybe you have questions about ACIP or AAP or hepatitis B or things like that. So it's called phages for children. Some people call them phages, some phages. You can call, you know, it's potato, whatever. So either one is fine. And I do a lot of vaccine studies. So these are the companies that sponsor some of those studies. Those are my only disclosures. And you know, none of them make phages, so there's no like related conflict of interest here. So the 3 things I'm hoping you get out of this are to understand a little more about the biology of these things, bacteriophages, and then be familiar with the clinical studies that have been done and understand a little bit about the challenges and maybe the future, what we have for phage therapy. So those are some electron micrographs of what phages look like. They look like little spacecraft. So I thought we'd sort of like go back and think about like antibiotics and why phages might be important given our antimicrobial resistance now. You know, you may think we've always had antibiotics, but of course we haven't. It's only been like 100 years, a little over a century that we've had antibiotics. So 1910 was the first antibiotic ever given to people. It was called arsphenamine, and it was for syphilis. It was arsenic-based, so pretty toxic. But you may remember the other, back then, arsenic, a bunch of different arsenic-based antibiotics. It was Paul Ehrlich, the German guy, who did what was done for a long time with antibiotics, and that is screening programs. So, you know, they knew that there were compounds that could kill bacteria, and they just went through large, like all different types of chemicals and tested them against bacteria. This is like the dawn of bacteriology, you know, the late 1800s, early 1900s. So they called this compound, there was like all different series. So there was like the 100 series, the 200 series, there was the 600 series, and the 6th in the 600 series, number 606, was this compound. And it worked really well to kill Treponema pallidum. And he said in his papers that he was looking for a magic bullet. So when you hear that term, oh, this isn't a magic bullet. That's Paul Ehrlich's, like he's the one who coined that term. And there's, yeah. And it was all about this salvarsan, arsphenamine for syphilis. In 1928, that's when the British Alexander Fleming accidentally really found penicillin. You probably remember this story. So he was growing staph on agar. And as you might imagine, like molds can blow into your lab if you're not careful. And if it gets onto the plate, then molds like penicillium can grow. Penicillium grew, and next to it, it killed the staph. So it was making something that was killing the staph, and then he figured out what that compound was and called it penicillin. And between 28 and the 40s, when the war broke out, the companies took to that and were able to make large purified amounts of it. And it was really the first time that a lot of antibiotics could be used for things like wounds and other things during World War II. And then in the 40s was the first time that we had aminoglycosides. So at Rutgers in Jersey, these 2 guys, Schatz and Waxman, figured out that streptomycin would kill tuberculosis. Now we've had this since then, you know, about 100 years. Obviously we've gone from all like natural products and antibiotics to semi-synthetics to now synthetic antibiotics. But there's this arms race, right? So we keep trying to make more and more antibiotics, and bacteria keep figuring out better and better ways of getting around everything that we think, is the coolest way of trying to kill a bacterium, and then the bacterium says, oh, hold on, I got a way of getting around that. So, talking about antimicrobial resistance, if you look at this figure here, you can see the millions of deaths, global millions of deaths have occurred in 1990, 2000, 2010, and now, and then what's projected with antimicrobial resistance deaths. So there's 2.8 million patients with drug-resistant infections in the United States right now each year, and 35,000 deaths, 1.2 million deaths from antibiotic-resistant bacteria in the world. So we do need, that's why antimicrobial stewardship is so important, and why new antibiotics, small molecules that will kill bacteria is important. But if we had another way, another product that could be used, that would be great, and phages are one of those possible products. I mean, in our world, bless you, our world, vaccines, of course, we think of as another thing for antimicrobial resistance, and there's a newish big program at the CVD to develop vaccines against pathogens that have developed a lot of resistance. So there's like a whole Klebsiella program right now. You may know, like, here we have some Klebsiella resistance, but we have a big program in Mali, and I know a program in India, in Pune, India, where the babies there, their neonatal sepsis, they are like all dying because they have these like carbapenemase resistant or ESBLs, or like a lot of Klebsiella, a lot of E. coli, a lot of Pantoa in Mali. So if you had a vaccine, then you don't need a better antibiotic, because if you never get the infection, it doesn't matter whether the infection would have been antimicrobially resistant, there's no infection. But we also need things to treat when they are resistant. So what are phages? So these are simply viruses that infect bacteria. So we all know about all the viruses that infect us. Other animals have viruses that are species specific for them, but there are bacterial viruses that infect bacteria. Those are bacteriophages. And you can see a picture, another electron micrograph there. So all those little dots with the lines going down, those are the phages sticking. And on the right side, that's the cell wall on the edge of the bacterium there. So some of the benefits of these are they're very species specific. And the good thing about that is, like our antibiotics, they work against groups of bacteria, right? So we tell you, oh, those are good for gram-negatives, or those are good for pseudomonads, or whatever. But they don't just kill the thing you want them to kill. They are going to kill other flora and other things as well, and they're going to have some effect on your body, maybe on your kidneys, or on your gut, or on your brain. These are very species specific, and it's a good thing and a bad thing. Like, the good thing is, if you have one that works against the bacterium that the person has, it will kill that bacterium and touch nothing else. But the problem is finding phages that work for the bacteria that you want is difficult. That's been one of the most difficult things in moving this whole field along. So as it says, there are no human tissue tropism, which would lead then to presumably to reduced side effects. And so far in the studies, that seems to pan out. So from the time that like antibiotics were first discovered, as you just heard, and through the first half of the 20th century, there was a fair amount of work on phages, but as the success, and both scientific and medical success, but also I think the economic success of making antibiotics went up, at least in the Western world, in the US and most of Europe, the research on phages went down. But Russia, Georgia, the country of Georgia, other places in Eastern Europe continue to do work on phages, and a little bit here. But a lot of the work here that's been done on phages has not been for therapy, but more for, you'll see there's other things that we use them for, that people use them for in the lab, like transfection. So antibiotics, people figured out, because they worked so well in the Second World War, they figured out how could they be mass produced. how could they make them really stable, and they were relatively easily studied because the dosing is in a weight, in milligrams or micrograms, whereas, for viruses or bacteria, if you're using those for therapy, they're in like colony forming units or numbers of viruses. They're hard to standardize. But as I said, the rise in antimicrobial resistance has spurred new interest in these phages. So the word phage, anything, whenever you see phage, of course, it means eater. So bacteriophage just means an eater of bacteria. As I said, they only replicate in single bacterial species, so there's lots of them. They're thought to be the most abundant life form on the planet, 10 raised to the 31. Actually it's estimated there are more phages than if you sum up all of the other numbers of organisms of all types, there are more phages than that. They're found everywhere that there are bacteria. So soil, ocean, fresh water, just everywhere. We have lots inside of us because you have bacteria in you. If you have a microbiome, you have phages that are trying to kill your microbiome. Some believe that every bacteria that exists has its own phage. I don't know if that's true. I told my wife that I was going to be giving you grand rounds. She's an adult ID doc at Hopkins. She said, "What's it on?" I said, "Phages." She's like, "You don't know anything about phages." I said, "Yes, I do." It has a similar, even though this, a lot of them are structured like this sort of like moon landing craft. It does have a lot of things that are similar to regular virus, like what we think of as viruses. That top part there looks very similar to like a human virus. So it has a capsid, a protein capsid. Inside is where the payload is, if you will, the DNA or the RNA. But the difference is a lot of these have these little feet, and that tail, as it's called, with the collar and the sheath, you can see, has a very small, what some people call a hypodermic syringe. So those little feet, they grab on to the bacteria, and then that whole tail moves down and pokes a hole, and then allows the DNA or the RNA to scoop in. Whereas most of the viruses that we have, they're either taken in by endocytosis, like they get engulfed and pulled in and then opened up, or they have an envelope that is fatty and there's a membrane on our cell that's fatty. They fuse and then they open up, and that's how the bacteria get in. But it's more like poking a hole, injecting it in there, yeah. So all viruses can do there's two different sort of paths that their life cycle can go down. You may remember this from medical school. There's the lytic path and the lysogenic path. So lytic means they get in and they kill the cell that they overtake all of the machinery of. Lysogenic means they insert their DNA or RNA that may turn into DNA into the genome, either in the chromosome or separately, like in a plasmid-like thing, and stay there, but they don't kill the cell. For therapy, you're looking really only for lytic type phages. So that's another challenge, is to make sure that your phage is not lysogenic, because you don't really want it just to put its genetic code into the bacterium. You want it to kill the bacterium. That's the whole purpose, is to be cidal. They make what are called holins. That's what pokes the hole through. Endolysins. There's a lot of science known about how the genetics of these viruses work. They will make 20,000 progeny per bacterium. They double very quickly, 20 minutes, so similar to like an E. coli. They're very species specific for each bacterium. As I said, they can also be lysogenic. They have great genetic diversity. They've evolved over millions of years with bacteria. There's been a lot of other ways that phages either have been used already or have been proposed to be used. So like the FDA and the USDA have some approved phage products to kill bacteria in the food industry. So like to prevent spoilage, they have anti-listeria phages that can keep listeria out of food. And that, to me, that makes a lot of sense. Like if they can continue to grow that field, because there's a lot of money there, I think, to be made and to be saved, and potentially like that science then gets you to the point that we can have more for humans. So there are some, and I think maybe there will be more over time. Plus, it leads to less of us being exposed to whatever the like antibiotics that might be used to do that same purpose, or there's people who are worried about radiation that's used to do this in food, even though it's probably fine. There's a lot of hype about that being a concern. So I think if phages could do that and they were safe, that would be great. They can be used as water indicators. They can be used for diagnostic. There actually is an FDA approved, I've never seen anybody use it, but an FDA approved diagnostic for Staph aureus, where they have a cocktail of bacteriophages for Staph aureus. They can tell you both, is it positive, and does it have methicillin susceptibility or resistance? And then in bioweapon preparedness, some have proposed using them to counteract, like if you had an anti-anthrax or an anti-botulism phage. Okay, we've already talked about all of these. So bacteria themselves can develop resistance to phages, just like they can develop resistance to antibiotics. So a couple of ways they can do that. One is they can isolate the DNA that is injected and destroy it, because they have DNases. They have their own bacterial mechanisms to both make their genetic code, but also to recycle, and that part of that recycling is DNases. So if they know this is a foreign DNA, they can grab it and then kill it or destroy it. Changes in the bacterial cell wall where the binding sites are that could prevent the adherence of the phage. So similar to what happens with like, penicillin binding, you can imagine it's a very similar process. So one of the main ways that some of our penicillins do not the whole class of beta-lactams do not work, is that the cell wall changes where it would bind, and then if it can't bind, it can't do its thing. Phages also have evolved to then change if the bacterial cell wall finds a way so it can't adhere, to make it so it can adhere to something else. So it's the same kind of like war of coming up with a way to be resistant and then overcoming that resistance. Lack of cell wall for the phages that need that cell wall. So for example, like mycoplasma and things like that don't have cell walls, then there would be nothing for it to stick to. Bacteria you've probably heard about CRISPR-Cas nucleases, CRISPR-Cas9 and other ways of inserting genes. Those are discovered in bacteria, and so bacteria may have some phage-specific CRISPR-Cas nucleases that can edit genes of the phage and disrupt its virulence. Phages can help antibiotics do their work. People have discovered that they can, for example, reopen porins in the cell wall. So one of the mechanisms of antibiotic resistance has to do with porins, which are like the ways that antibiotics can get in. And if phages reopen, if they sort of got closed, if you will, so the antibiotic couldn't get in, but the phage reopened it, that would allow antibiotics to do its thing. So they could work in synergy. Same with efflux pumps. There are some bacteria that have pumps where antibiotics can get in, but then they pump them back out, so they can't do their work. And there are phages that can bind to those pumps to make them less effective in pumping the antibiotics back out. Phage binding may lead to decreased virulence of the bacterium, in that some phages bind to some of the toxic parts of bacteria, like the O-polysaccharide of LPS. They also have ways, as it says there in the last bullet, of preventing other phages from binding. So they're sort of like fighting each other to take over the bacterium. So they were really discovered back in 1915 by these two men, Frederick Twort and Felix Derel. Derel was a French-Canadian working in Paris at the Institut Pasteur. And he found them during an outbreak of dysentery among French troops. And then he and the interns that were working with him ingested the phages themselves. This is like something that happened a lot. Like the ID docs now, we don't do this anymore. But back then, this was a thing. There's a lot of stuff out there about people in public health and ID and maybe others, but doing things on themselves first, ingesting things like this. So, and the boy, they gave it to a boy with dysentery, and he got better. So they decided maybe this would work. So there's all different routes that these have been used. Putting it on the skin, like on wounds on the skin, taking it orally for GI infections, inhaled for respiratory infections, and intravenously for things where you need to get it to an organ that the blood would send it there. Some of the phages seem to penetrate biofilms better than a lot of antibiotics. You know that bacteria can make these biofilms, so they kind of bind together, especially on plastic and hardware, but it can be on other things like scars and valves and things like that. So that there's a very non-active surface of the film, but then active bacteria underneath. And they talk to each other essentially to keep that film. Antibiotics most of them have a very hard time penetrating into those biofilms. And it's one of the reasons that we talk about things like source control, why it's very hard, for example, like with bacterial endocarditis, for us to treat it only with antibiotics. A lot of endocarditis because of these films. It's why it's hard on like catheters for us to get the antibiotics to work on those catheters, because not only is it sticky and there's not any like blood going right to the catheter, but they also have these films on. So if phages could make their way through, that would be a big advantage. They've been used for dysentery, for musculoskeletal infections, especially for prosthetic joint infections, which, as you know, are very difficult to treat without taking out the prosthesis. For recurrent urinary tract infections, we see, and I'm sure you do too, a lot of kids and adults who have a lot of recurrent UTIs, especially if they have abnormal anatomy or if they have neurogenic bladders. Skin and soft tissue infections, including burns, pulmonary infections, especially cystic fibrosis. You'll see there's been a bunch of work on this because kids with CF, they start off with sensitive organisms, and then over time they're there so long and they're treated with so many antibiotics they become more and more resistant. So like Pseudomonas is very difficult we can never essentially get rid of it in kids with CF, but we can like keep it at a low level, and people have used phages to try to work on these multi-drug resistant CF Pseudomonas infections. And then other devices like ventricular assist devices. So the clinical experience is not as large as we would like, and many of the studies are not controlled, which makes it difficult to know how well it worked. You'll see a lot of them, they say, oh, we gave it and people got better. And we're very skeptical when people say we gave it and people got better. We like to see RCTs, right? So the first published RCT in the United States was only in 2009. It was under IND, meaning investigational new drug, at the application at the FDA. It was published in the Journal of Wound Care. They gave this topically to people with chronic venous leg ulcers, and there were 20 people that got the phages and 22 people who did not. They followed them. They gave it every week for 12 weeks. And the phages were like a cocktail that worked against Staph, Pseudomonas, and E. coli, which commonly would cause these infections. They were unable to show any benefit. Now, it's a very small number of people, so it might be difficult to show benefit anyway. But they didn't have any worse adverse events than the ones who got the phages than those who got the placebo. So disappointing, but it meant they didn't move forward with trying that cocktail on other people with wounds. There's been reports of using this for resistant Acinetobacter baumannii intra-abdominal infections. A lot of anecdotal reports, and I'll show you a table of the ones that have been done in pediatrics. Now, this is what I mean. There's like a retrospective review of a whole bunch of studies, so 30 studies, and in 26 of them, 86%, they said that they showed benefit. You have to take a lot of caution. That sounds really promising, but right. The other way that I look at these things that look so promising, you're like, if it's that promising, people are going to move to think, we would have more, good evidence that these will work better. But it is good to see that those numbers, right? 87% showing some kind of benefit. 4 registries of people 16 and older, and again, 80% of the participants in those registries, they said that there was some improvement. Now, these often are people who've had a long history of, you'll see, of getting antibiotics and not responding. So the fact that they're showing improvement, it's a good sign that I think people should continue to look at phages. There's been studies for foreign bodies and hardware, and you can see there a 2010 study said that 20 of 21 infections of prosthetic devices were successfully treated with no serious adverse events. Seems too good to be true. I mean, I do a lot of vaccine studies in very healthy children. We always have SAEs. So having 21 complete studies of people with prosthetic devices, usually people with prosthetic devices have a lot of comorbidities, and not a single SAE, just makes me think, okay, these are not like as rigorously done as the studies that need to be done if we really want to know if phages work well. Somebody had something, right? So like here, for example, 0 SAEs in 1,100 patients with MDR organisms. Seems too good to be true. But some of the AEs that could happen would be like if toxins are released from the bacteria when you kill them with the phages, if there are leftover remnants of bacteria because you used bacteria to generate those phages. You might imagine that there could be flushing, hypotension, and fever, especially when it's given intravenously. And that you could trigger an immune response to the phage, and that whether or not that would lead to any, cytokine problems, who knows, but you would expect there's going to be some, even if they're unrelated, that there would be reported adverse events. So in pediatrics, there's very few studies. There was a randomized controlled trial that was placebo-controlled in 2015, where they gave an oral phage against E. coli in Bangladesh, in Dhaka, to children with acute bacterial diarrhea. No SAEs attributable to the phage therapy. And in an interim analysis of the first 120, there was no reduction in diarrhea compared to the placebo. So they halted it for futility. So you probably know, like when we do these studies, sometimes we have big studies, we will at some point do one or sometimes even more than one interim analysis, and there's usually like multiple different outcomes of those interim analyses. One is you've already answered the question, you don't need to continue the study, right? So you've got your answer. It was a great, like when I did, one of the things I did when I was in Africa was PrEP, HIV PrEP. And we got about 3 years into the study, there was an interim analysis, and it worked so well, they said, you cannot continue to give anybody placebo. You have to, what we did was we took all the placebo recipients and we randomly assigned them to either Truvada or tenofovir, the 2 other arms, the 2 antiretroviral arms, and then followed them to see if one of those was better than the other one. So that's something that can happen in an interim analysis. Or the other one is they can do what's called a conditional probability analysis, power analysis, to see even if you were to go and finish the entire study, could you show a difference? And in this, and if you couldn't, that's called futility, right? It's like, it's unethical to continue when there is no possibility that you could show a difference. So the fact that after the first 120 there was no difference, they halted it for futility. There were a number of reasons cited as to why it might not have worked. And the primary reason, if it's really true, what everybody says about how well these things could work, is that they didn't have phages that were specific to the child's pathogen. Like, you need to know that what you're treating is the exact thing that this phage will kill, or to have a cocktail that kills most of the things that might cause what's going on with them. Yes. Well, you give a lot, so I'll show you what some of the doses are, but you're giving a lot of virus, and those viruses each get into bacteria, and when they get inside, they replicate, and then they replicate to this large number, and then they break open the bacteria, and then each one goes to only to that same bacterium, like Staph aureus or E. coli or whatever, and goes in there and does the same thing over and over again. So like if it, not to any other bacteria, exactly. So if you have, all those bacteria that you have in your gut, the hope would be you could, let's say you only gave this for Vibrio cholerae, and it killed all the Vibrio, but it's not going to kill your regular E. coli, your regular Klebsiella, your good bacteria, your microbiome. Yep. Russian study of 30 children, 4 to 15 years old, and they said that there was clinical improvement. Again, that's not a controlled study, so not great. And then 14 other studies with anecdotal reports. And I think that's what the next slide is. There we go. So these are pretty much all of the studies or individual cases that has been given. And as you can see under these outcomes, often improvement. So kids with cystic fibrosis, kids with internal fixation after a traumatic fracture, lung transplant. So anecdotally, looks like maybe they could work, but these are all where they knew the pathogen, they had a prolonged illness, they made a phage or found a phage in a library that worked specifically for that pathogen, and they gave it over a long period of time. So again, you have to have a lytic, a cytophage, and not, and these are some of the issues with finding these phages for treatment is you need to make sure that it's lytic. And then once it's identified, the organism, the bacterium would be tested against a library of phages that may work, which would be similar like antimicrobial susceptibility panel if we had these libraries. There are people making libraries, but there's not enough of them yet. There's some academics that have them. There are some industry labs, some military labs, and some places in Europe and in the UK and Australia where they're starting to make bigger libraries. There's not really a national resource yet in the United States. Staph and Pseudomonas are the ones that are most commonly that people have used them for. There's the thought that we could genetically engineer them and it would be faster if you knew exactly what genes you needed to put in order to make a phage that would work perfectly for your organism. That hasn't happened yet. You can see here what one of the major problems would be in the second bullet. The mean time from request until you can actually give the phage is 171 days. So this is not going to work when a child shows up acutely and you're trying to kill whatever they have. This is somebody like, okay, cystic fibrosis, and you keep following them. They get cultured intermittently. Over time, you see that now they've developed a very resistant organism, and you say, okay, we're going to try to find a phage that will work against that organism while you continue to treat them with antibiotics. There's strict storage conditions. There's a lot of issues. You need to make sure you find one that's for the right bacterium, that you're going to hit the right infection site, the right route of administration, and the correct host. There's currently no guidelines. Like, there's no, I was sitting downstairs for the last hour going through Red Book chapters because we're writing the 2027 Red Book right now. There's no phage chapter in the Red Book yet, but maybe in the future there would be. There's no guidelines from anyone, so each of these is done under compassionate use, essentially, what we call an INDEA for a single participant, or in a study if there are studies being done. The regimens that have been used, no one really knows yet like what the right regimens would be. So people sort of mimic antibiotic regimens. Once a day, twice a day, 4 times a day, 4 weeks, 6 weeks. Like nobody knows yet like what the right thing to do is. Assessment of efficacy can be difficult. We have pretty good guidelines now, although it's gotten more complicated, as you know, like what is susceptible, intermediate, and resistant for antibiotics. But we don't have that for phages. You would need to have that to know, like the FDA would want that if we were going to be saying, okay, you have a patient, they have this problem, you want to treat them with this phage, you need to know what its safety profile is and what exactly the efficacy is going to be or the susceptibility would be. And it's difficult to know in these studies because they're always pretty much always co-administered with antibiotics on the safety. Is it, if there's a problem or if there's a benefit, is it because of the antibiotic or is it because of the phage? So as I said, and we do these, not phage therapy, but a lot of these single patient IND expanded access, what we call compassionate use. So there is an experimental product available, and it can't be given off-label because it's not licensed yet. It's not easily, either someone's not eligible for the clinical trial that it's being tested in, or it's not, they're not at a place where there is a clinical trial for it. You can get these what are called single patient INDs. So our IRB, I'm the senior vice chair of our IRB, we approve these fairly frequently for people who say, this person has this type of this weird type of leukemia, there's an experimental product, they can't be in a clinical trial, we want to give it to them for a single patient. But it's a lot of paperwork, it's a lot of FDA approval, IRB approval, a lot of things you have to go through to get there. And as I said, typically used late stage, like for CF or MDR organisms. Some people have tried cocktails where you use multiple phages either against one bacterium or against multiple bacterium that you think are there. There can be potential synergism with antibiotics. There also might be ways that the phage would prevent the antibiotic from doing its thing. The human host may make antiphage antibodies that could reduce their activity. If you don't identify it, a phage as lysogenic, then you're probably not going to get any benefit from it. There are currently no, quote, broad spectrum phage cocktails, so we can't give like a meropenem equivalent where somebody came in and you say like, we don't know what they have, but they're really sick and septic. We want to give them top line. We can't just say, okay, this is the phage thing that would kill everything. There are none of those available. They're costly, and as I showed you, it's time consuming, and they still have to prove each time that, and you want to make sure if you're giving something, especially, you're giving it intravenously to someone, that it's pure, that it's sterile, that you know exactly what the dose is that you're giving, and it's not probably reimbursable by insurance. So right now, we're not there yet. In the future, hopefully, we would have more libraries that you could pick and choose. Even if we couldn't do it for acute infections, you would be able to say, if I have this type of organism, Acinetobacter baumannii, and I have a kid who had scoliosis, has rods in, I don't want to take the rods out, could I have a phage for that? If we had libraries and they, a company or somebody could send you that I think would be maybe the next thing that we could get to. Yeah, I think there's future use for AI to develop lots of things, including antibiotics, and probably for phages, phage libraries as well. Sure. Yeah, you have to have them. Either you have to use AI to genetically design the phages the way you want them, or that you have libraries and AI helps you to choose which among the phages are the ones that you need. Yeah. So as it says here, considerable effort before they're going to be considered standard of care. Things like cystic fibrosis, recurrent UTIs, immune-compromised children who can't clear bacteria, infections with hardware would be probably the first uses for it. And they need to be tested, just like for alternative medicine type things. I think one of the big reasons why most people don't recommend them as frequently as maybe we should be is because so many of the studies are not done to the level, the rigor that's necessary for you to feel really confident that they work. When you do like big case series, or you don't blind it so that you can't tell, where there's a lot of subjectivity in the outcome. And so I think people in the alternative medicine world have changed to do a lot more randomized controlled trials. We need that for phages too. We need to know what the dose, the dosing frequency, the route, and the duration would be, and better assess and standardize susceptibility. So some key points to end. Phages are viruses against bacteria. Specific phages attack specific bacteria. Currently no licensed, but hopefully in the future we'll have them. They've been used experimentally for difficult infections, and with additional data, they may play a role in treating some infections in the future. The other thing my wife said this morning when I told her I was giving you guys grand rounds was, oh yeah, that saved so-and-so's life. And I was like, who is so-and-so? So one of her colleagues at Hopkins, her husband, I believe, had some horrible infection and got phage therapy, and they presented it to everybody there. And that's what, she said that she's saying that her husband's life was saved by phage therapy. So I think in certain small instances, we may have some people who we would want to try to find out if we could find a phage for them. For now, I think you probably have a little time before you're going to have to look up the phage chapter in the Red Book. So.
At Hopkins, are they using them at Maryland? And anybody in the adult world?
Not that I know of. I've never seen anybody that's used them. The main place where I took this from was in San Diego. John Bradley, who any of you who use the little yellow Nelson's pediatric antibiotic book, he's the main editor on that, and he's been that forever. He's done he's treated some people with phage therapy, and he and someone at the Naval Hospital there did a review of everything that's ever been done in pediatrics and phages. And that's a lot of where I got the background information for this. But yeah, we've had some pretty bad MDR type infections in children at our place, but we've never gotten to the point where we had absolutely nothing. The adults sometimes do have just absolutely nothing to treat them with. And that's part of that is we're pretty stingy. We don't give people meropenem very easily. They're not getting meropenem when they come in. They're not getting, anybody who's worked with us knows, like, we're trying to keep people from using kind of willy-nilly using things that they don't need to just because it would treat everything.